So the next speaker is Dr. James Mezhir. He's an assistant professor of surgery in the Division of Surgical Oncology at the University of Iowa. He trained at University of Chicago and a fellowship at Memorial Sloan Kettering, and he's currently an associate editor for the Journal of Surgical Research.
Thanks, Jason. Thank you, Dr. Katz and Dr. Esbat, for inviting me to speak here today at this very informative and extremely well-organized symposium. I'm going to be talking to you today about benign liver tumors. I have no disclosures. This is our University of Iowa campus. For those of you who think that Iowa is just cornfields, we actually have buildings. So, case presentation. This is a patient I saw a few years back, a 44-year-old healthy account executive for John Deere. A CT was performed due to a quote-unquote family history of cancer. And here's the CT. It revealed a lesion in the liver, and the read was a 2 by 2 by 1.5 cystic mass consistent with cystadenocarcinoma of the liver. So I had to go and look up what a cystadenocarcinoma of the liver was because they're not very common, and there are only case reports. So I obtained an ultrasound, a contrast-enhanced ultrasound, and the read was the lesion's sonographic features are consistent with either hemangioma, adenoma, or FNH, and they recommended an ultrasound-guided core biopsy. We then obtained an MRI, so this is the third test the patient had. Low T1, high T2, and multiple internal septations, a few which mildly enhanced. The lesion measures 2.2 by 1.8 by 2.5, versus previously 2.1 by 1.7 by 2.4, and again, the read bringing up the word carcinoma. So at the University of Iowa, we have something called MyChart, and the patient, of course, went on to MyChart and read this report, and he called me very upset and said, my tumor has grown significantly. I mean, it grew, a millimeter or so in each direction, which I told him is not significant, and he said, I have cancer, this has to be removed. So the point of this is we see a lot of these incidental lomas, and Dr. Sung talked about incidental lomas of the pancreas. We see a lot of incidental lomas of the liver. And one of the things that I think are very important to highlight is that this requires multidisciplinary management. I presented this case at our tumor board, where we have a dedicated radiologist who reads these films, and he was able to say, this is a complex hepatic cyst, you don't need to do anything. And the lesion has been stable for 3 years without intervention. So now I do annual ultrasounds on him. So benign liver tumors, or BLTs if you will, are rare solid neoplasms. Also they can be cystic, obviously, seen mostly in young women. And it's important to mention that this is in cases where there's no evidence of cirrhosis. Patients with cirrhosis are a different entity. The majority of lesions include 3 major types: focal nodular hyperplasia, also known as FNH. The vast majority of them can be diagnosed with MRI, and I'm going to show you a little bit of new data that demonstrate that we now have information we can use with biopsy to designate them as FNH versus adenoma, so IHC or immunohistochemistry. Hemangioma, the majority of them can be diagnosed with imaging, and hepatocellular adenoma, which are very important lesions to be able to carefully identify because they have risks associated with them. They can rupture and bleed, and they can progress to cancer. So there are now molecular tests that can be performed to help us diagnose these lesions with a biopsy. The management strategy obviously differs among these lesions, and the challenge lies in lesions with atypical features like I showed you earlier. A basic hepatic cyst can be diagnosed with a CT scan and left alone, but when you've got a solid component or something else concerning and it's atypical, those are the lesions that we tend to struggle with. And you should be able to determine a cancer risk in select cases. These lesions are being encountered with increased frequency because of the fact that everyone who comes into the emergency room gets a CAT scan for obvious reasons. Also, we pick these up when patients are undergoing surveillance for lung nodules. As I said, most hemangiomas and simple cysts can be diagnosed with MRI and safely observed. And I think now in 2014, now that we know a little bit more about the natural history of these lesions, we can discharge